All right, good afternoon, and thanks for joining us. I'm Devin Farians, Client Solutions Executive here at Employers Health. Currently, all attendees are in listen-only mode. Please use the Q&A function on the left-hand side of your console to submit questions. We'll address them at the end of the presentation. And a copy of the presentation is available for download and can be found by clicking the paperclip at the bottom of your screen. So watch for the recording to arrive via email tomorrow. Upon exiting the webinar, you'll receive a survey to provide feedback. We truly appreciate all attendee feedback as it helps us shape our future programs. So joining me today are Jen Roberts, Vice President of Employer Strategy at Hello Heart, and Hannah Weitzel, Clinical Advisor at Employers Health.
Thank you, Devin. So to kick off the presentation today, this isn't an all-encompassing list, but I wanted to set the stage about what disease states I'm really going to be focusing on. And this covers some different types of heart and vascular diseases, but I will really be focusing on excuse me, high blood pressure and high cholesterol, as these are the main disease targets for preventative actions when it comes to cardiovascular disease. So treating high blood pressure and high cholesterol, whether this is through lifestyle changes or medications, are really our best defenses at preventing things like heart attacks and strokes, as well as some of the other diagnoses listed on the screen. And you might be familiar with why these diseases are referred to as the silent killer. But in case you're not, this is because you can't physically feel the effects of high blood pressure and high cholesterol until oftentimes irreversible damage potentially is already done. And I think this emphasizes the importance of screening early and often. So this next slide depicts an ASCVD risk calculator, and ASCVD stands for atherosclerotic cardiovascular disease. And this is a tool that physicians use to determine a patient's 10-year risk of developing a cardiovascular issue, maybe heart attack or stroke, or any of the diseases mentioned on the previous slide. And physicians use this tool to pick appropriate interventions, and it requires patient factors to be inputted, such as age, gender, and family history. So those cannot be changed. However, there are several modifiable risk factors that can be managed, and this would be the basis of any clinical recommendations that the doctor might give to the patient, or it would be the basis for any employer-driven health initiatives to support the lifestyle changes within their employees. So if and depending on the percent that's spit out of this calculator, the higher the percentage, the higher the risk is considered. But this isn't the only thing that is used to determine recommendations. There's also that patient-physician relationship that would be taken into account as well. And if a physician is bringing up this risk calculator, they're likely going to make lifestyle change recommendations first, or maybe lifestyle changes in combination with medications. And I'm going to be referencing lifestyle changes quite a bit throughout this presentation, so I wanted to briefly cover at a high level what this entails. And it is not all inclusive. This includes primarily diet and exercise interventions, but there's also sleep health and smoking cessation that's also considered in the lifestyle change realm. So as far as from a nutrition perspective, shifting diets away from predominantly processed foods and more towards plant-based whole foods, I think a good rule of thumb is to focus on foods that your great-grandparents would recognize. And the Mediterranean diet, as depicted on the screen, is a great example of a diet that kind of aligns with these natural food focused. And from a physical activity perspective, the recommended amounts of exercise is around 150 minutes of moderate aerobic activity per week. So this includes things like brisk walking, or 75 minutes of intense activity per week, which would be considered jogging or running. And this by no means has to occur all at the same time. I actually recommend breaking it up throughout the week. So 5 days of 30-minute exercise chunks would fit the bill. And I think from an employer perspective, potential ways that they could support these lifestyle changes within their population could maybe be to offer healthier food options if they have on-site food court, maybe offer healthier options at a lower cost to the employees. Or if employees have a primarily sedentary occupation, maybe allowing time for walking breaks throughout the workday, just to break up that long periods of sitting. And that concludes the lifestyle discussion. So shifting gears to look at trends that we've seen within the employer's health book of business. So as a whole, a lot of the spend for specifically cardiovascular disease are really going to be driven on the medical side, just because of the high generic availability, especially for some first-line agents. And these medical expenses are predominantly driven by ER visits and surgical procedures, to name a few. And Jen actually has a ton of really great statistics covering the overall impact of this that we'll get to discuss later on in the presentation. So the chart that I have on the screen depicts many of 3 disease classes within the cardiovascular realm and the overall per member per month gross cost for these drug classes. So you can notice that antihypertension or high blood pressure treating agents are widely generic. This keeps the per member per month really low, between $1 and $1.50 per member per month. And this is, you can say the same for the high cholesterol treating agents that come around $2.50 per member per month. However, we have seen a slight increase within the anticoagulant space, and I think this isn't necessarily a new trend that we're seeing, but there have been a few recent market dynamic changes that I wanted to highlight. So the reason that we're seeing an increase within the anticoagulant class, to give some background, historically, anticoagulants that were used were warfarin and Coumadin as first line. However, this is a really difficult drug to take. It has a ton of food interactions, and it requires a lot of frequent clinic visits to adjust the dose, where newer agents have entered the market since. To name a few, this includes Eliquis, Xarelto, and Pradaxa that don't have dietary interactions and have much more standardized dosings that doesn't require so many frequent blood draws. And these agents have only had branded formulations available up until the end of last year, where Pradaxa had its first generic launch. And this is the first generic opportunity we've seen in this class, and I think it's really great to see, as the spend and overall gross cost of this class has been increasing for quite some time. And I think the importance of this is better depicted on the next slide. So this is just another visual looking at some of the pharmacy trends that we've seen in the cardiovascular space for 2022. The pie chart on the left represents the total amount of prescriptions in this space, and then the chart on the right represents the total gross cost broken out by the subsequent drug classes that we see. And the dark teal, it's kind of a sliver at the top of the total prescriptions, and the right on the total gross cost, this represents that anticoagulant class. And you can see that even though these drugs only represent a very small amount of total prescriptions, they are almost a third of the overall cost within the cardiovascular space alone. So this, hopefully, once we see more generic entrants come into the marketplace, we'll maybe see that overall costs go down. Another aspect that I wanted to highlight, so since the majority of the prescriptions are really going to be driven by high blood pressure and high cholesterol agents, where the majority of the cost is going to be more so towards the anticoagulants that I mentioned, as well as high cholesterol. And to focus in on the high cholesterol drugs, which is the light purple, there's a pretty wide range of different types of drugs within this class. So the first line treatments have a lot of generics available. However, there's also a very high volume of utilizers within this class. And there's also another subclass of drugs within the high cholesterol space called PCSK9 inhibitors. So this is actually a specialty specialty products that fall within this class that are not as commonly used, but are relatively more expensive than some of the first-line agents. And I will dive into more detail within that class on this next slide. So this table depicts some of the most commonly used drugs to manage high cholesterol, as well as their average gross costs per prescription based on 2022 data. And the way that they're ordered, the ones at the top are typically the more first-line options, and if a member maybe doesn't completely respond or their cholesterol still remains high after the initial medication, they might progress further down, depending on the case, of course. And I wanted to highlight, especially in the statin and fibrate classes, even though there's a ton of generics available, not all generics are created equal. Well, not all generics in this space are priced equal, I should say. You can see within the statins, generic costs range from $4 to over $200, and within the fibrate space, $32 to almost $200 as well. So this allows for potential management opportunities to potentially prefer more cost-effective generics first prior to some of the more expensive ones. And second to the last row on this table, the PCSK9 inhibitors. This includes products Repatha and Praluent. So in contrast to all of the drug classes further up on this table, so these are the specialty products, and they're also an injectable, whereas all of the above classes are going to be oral options. So these are typically reserved for more refractory cases of high cholesterol and maybe genetic disorders that cause very high cholesterol accumulation as well. Lastly, one of the newest changes in this space, Leqvio. It is the first drug in its class that was approved last year, and it has a very different mechanism compared to many of the other options that were previously available. So Leqvio is actually an injection that is not administered by the patient, and it's administered by a medical professional. And in contrast, after a loading period, you only need to receive it every 6 months. So it's definitely a novel mechanism and a novel dosing frequency. So it's interesting to see how that will impact. I know we've predominantly expected it to be falling under the medical benefit. However, we have seen a couple fills under the pharmacy benefit last year. So just something to keep an eye out for as well. And as far as overall recommendations or actionable items, check with your PBM to ensure that there's appropriate utilization management on the PCSK9 inhibitors, as well as Leqvio. And I will say, if you are part of the three PBMs within our book of business, they do have management on these products, so you don't have to check if you're with us. Now, of course, it doesn't matter how effective any of these products are if members aren't taking them as prescribed, of course. So to transition over to some adherence metrics, the definition of adherence within these statistics, so this is using the mean possession ratio, or MPR, and this looks at the amount of day supply that any patient has on hand at any given time. And a percentage above 80% is considered adherent. And so this is essentially checking to see if members are picking up their drugs on time. And overall, it's great to see such high percentages. And to caveat, these statistics will never be at 100% due to medication switches, which aren't accounted for. So if someone switches from one high blood pressure agent to another, they might clinically, I would consider them adherent, but by these metrics, they would not. And as far as boosting adherence within a population, allowing 3-month supplies, if your state allows it, can help with these metrics. But of course, the real outcomes result out of members actually taking them when they get home, which these statistics don't necessarily have insight into. So that's why I believe education is a key factor when to encourage members, if they understand the importance of their medication and how it's benefiting them, I believe they're more likely to stay adherent at home. And I think education overall is paramount to the management of any disease states, especially diseases like diabetes and obesity. These actually play a big role in cardiovascular risk. You might have noticed that diabetes diagnosis was included on that ASCVD risk calculator that I mentioned. And actually, adults with type 2 diabetes are 2 times more likely to die from heart disease or stroke than those without diabetes. So it's pretty powerful statistics. And I think as from a population health perspective, I would think successful initiatives in one are likely to help another, as these disease states are very commonly seen together and interact in a meaningful way. So considering the big picture with this, making sure that you're assessing both medical and pharmacy benefit data. Disease states like diabetes have a big impact, arguably, in both the pharmacy and medical benefit, whereas the most expensive heart health interventions are really going to be seen on the medical benefit due to such high generic availability. And lastly, considering social determinants of health within your population to make sure that the benefit offering as a whole doesn't have any potential gaps in it. And from a book of business trend perspective, we've seen a lot more interest in solutions related to all three of these topics. And I think this is especially true as it relates to the increasing popularity of the GLP-1 class. This stands for glucagon-like peptide-1 agonist, which is essentially the receptor in the body that is targeted by blockbuster drugs, Ozempic and Victoza. Now, these drugs have received a ton of media coverage in the past few months. And something you might not know about these drugs, Ozempic and Victoza are actually indicated to help reduce the risk of major cardiovascular events in adults with type 2 diabetes. So these drugs are not only helping blood sugar control and weight loss, but heart health as well. And this is definitely reflected within the data. So you can see on the slide within 2022, the per member per month trend of Ozempic alone more than doubled from $4 per member per month to over $8. And I think this creates a unique situation for payers, as these products are very effective and have multiple benefits. However, they are relatively more expensive than many other diabetes treatments, costing around $1,300 a month. And due to the increasing popularity, I think the trend overall, there's a lot of management options that are available that I'm not going to dive too deep into for today's discussion, but especially for clients that might not cover weight loss, they might see members trying to fill the diabetes indicated products off label, even if they don't have diabetes at all, to seek that weight loss benefit. So there are many management opportunities within that space. In addition to this, all of the clinical trials for the weight loss studies were actually studied in combination with lifestyle and nutrition coaching. So I believe for any employers that are considering covering obesity products or do cover obesity products, I think the most robust approach towards that category would be to potentially offer a lifestyle-based program or lifestyle-based support to ensure that they're receiving the full benefit of those products. And with that, that concludes the clinical portion of our discussion today, and I can turn it over to Jen at this time.
Thanks, Hannah. Don't go away because I have a ton of questions. And in particular, I think it was interesting, you were talking about the outcomes of these drugs that they say, in conjunction with lifestyle. And I think that piece is missing a lot. You want people to take medications that are indicated, you want them to be adherent, but in these types of cardiovascular, it's on the individual to take action and change. And when we look at this next slide here, it's kind of the cardiovascular cost triad. And I know we were talking about the silent killer 2-year plan. And I think that's interesting because when you showed the data earlier about the utilization versus cost. And so, for example, with hypertension, you see that such a high utilization, the cost is low. But if people don't manage those conditions, then they end up as high cost claimants or they end up on specialty meds. And so just kind of creeps in there. So if you think about lifestyle behaviors, if people are not adapting healthy lifestyles or they are adopting unhealthy lifestyles, you're going to start seeing that show up on your medical plan as different diagnoses and different treatment. And then likely you'll see pharmacy utilization as a way to manage essentially lifestyle behavior. And I was just wondering, in your opinion, do you see people ever come off drugs if they can manage the lifestyle behavior? Do you see people coming off hypertensives and hyperlipidemics? What do you normally see?
Yeah, my perspective is ideally that would be the goal, especially for early stages of the disease. The earlier you catch it, the higher the chances that you might be able to control with just lifestyle alone. And honestly, I would consider even a reduction in dose to be a win. And I think this can actually be one of the big motivators for some individuals to commit to long-term lifestyle changes with the goal of either reducing or eliminating the need for medication. And even though we have effective treatments, of course, they don't come with their own risk. I covered some of the treatment options very quickly today, but there's always going to be the potential for side effects, whereas I would argue that lifestyle changes have the exact opposite, and they'll positively impact other areas of life, such as mood and mental health as well.
Here's some other costs to talk about to double up with what you were sharing. And as we're seeing kind of this unsure in what's going on in the market, is there a recession coming, a mini recession? We know we have supply chain issues and that's contributing. I luckily have chickens at home, so I'm not paying $10 for a dozen eggs, but I hear it's pretty expensive out there. My orange juice is very expensive right now. So what we've seen from this year to last year is a 20.6% increase in the cost for medical insurance. There's the expectation that those costs are going to continue to rise because the supply chain lag over the past 2.5 years has not been passed on in terms of increased provider payment or increase for supply. So if you were going to the hospital and you needed a Band-Aid or you needed an IV bag, those prices had not been passed on yet. And they're going to be passed on at some point. So there's this expectation that the increase next year could be even higher. And then just taking that example, the inpatient increase has gone up $4,000 from the past 20 years. And that doesn't sound like a lot, but when you're looking back at your plan and you're looking at how many members you have, for our consultants on the phone, I think they definitely know what kind of an impact this could have. And so one thing, and I come from the consulting side as well, and I've been doing it for quite a long time, and it was always medical cost more than pharmacy, and pharmacy was like maybe 20% of your spend. And we're seeing that creep up more and more in terms of total spend. So Hannah, what's going to happen with pharmacy? Is it going to eclipse medical costs, or when would that maybe happen, or maybe it won't?
I think overall, especially just due to the nature of cardiovascular disease, more prescriptions, especially the preventative ones, aren't necessarily a bad thing. And of course, as more and more drugs enter the market, especially some of the newer agents might have significant benefits over older treatment regimens that have the biggest impact. There is a potential for costs to continue to grow. However, this also creates new management opportunities as well. I think a good example of really impactful drugs would be the GLP-1 class, of course. I mean, even before the weight loss products, Wegovy, entered the market, Ozempic was already at the top of the treatment paradigm for patients at risk for cardiovascular disease. So I think overall the costs are likely to increase. However, it's not necessarily a bad thing if it means we're preventing more long-term consequences down the road.
That's a good point. I also have a very similar statistic that you showed in the pie chart. So currently in the US, age 18 and up, 60% of adults have high cholesterol and or high blood pressure. And I just stop that for a second, 68% of adults. So presumably we only have adults on the call today. So that's probably 68% of us fall in this category. When you were showing your pie chart earlier, that looked about similar. Close to 2/3 were utilization for hypertension and cholesterol. And these can lead to significant costs on the medical side. Just a little bit about cardiovascular in general, thinking more from the medical side, it's the number one most prevalent chronic condition, it is also still the number one cause of death. Here's some kind of related to higher at-risk groups. There's 30% more heart disease in Black adults compared to white adults. This is in the US. Black, Asian, and Hispanic men are 2 times more likely to have uncontrolled versus controlled hypertension. This personally gets me a lot is women are more likely, 2 times more likely to have a heart attack than men. So we both see it's the number one cause of death, but for women, it's impacting them at a 2x greater percentage. There's a lot of reasons behind that we don't have to go into the call today, but we're kind of gearing up for Women's Health Month coming up in May with a campaign about if you feel something to say something. So anybody who's on the call that be interested in basically some employer-based educational content on women's risk and women's health risk related to cardiovascular disease, happy to provide that. And thinking of I'll go to the last one, like 1 person dies every 34 seconds. So this is a big impact on your population. And like Hannah was saying earlier, it's silent. You can't typically feel it until you have essentially an event, right? Or you've created, irreversible damage. And this is your employee population that you're looking at. So when you think of productivity, presenteeism, absenteeism, even if you're just kind of generally not at your best, that impacts you in other ways that go way beyond the medical or the pharmacy plan costs. It's somewhere around $10,000 a year for individuals on a PMPY with cardiovascular disease compared to those without a chronic condition. You're looking at a difference of $5,000-$6,000. So kind of start multiplying that. Think of that 68% of a population of your population, and this is the dollar amount, and it's an impactable dollar amount. So if you can focus on a good medical and pharmacy plan management and then reinforce with the lifestyle change, there's a huge dollar amount that you do have some ability to make an impact on. Some of the lifestyle changes that we were talking about, thankfully, we've had a really wonderful public health response finally to smoking. So about 12.5% are current cigarette smokers. I think this statistic, Hannah, is going to go out of the water in the next probably 5 years with vaping, especially on the rise for young people. And I mean like teenagers, young people. So it's almost like that cycle starting over again. So something to be aware of in your population. Around 94 million Americans have high cholesterol right now. 47% of your workers have hypertension. Around 42% are obese. Those things are not helping each other. And then that 63% who have high blood pressure, and cholesterol. So they've got 2 very serious cardiovascular conditions that you can still work on the preventive side before you get to heart disease and further down the road with that in terms of medical management and pharmacy management. So a little visual on what is heart disease. So it's kind of the pumps and the pipes of your cardiovascular system. And if they're clogged up and they're not working well, you're going to lead to a myriad of different impacts. And we've got some kind of articles here. We're happy to send these links out. So it's interesting to me. My whole background pretty much has been doing my career clinical research in cardiovascular disease, primarily cardiovascular disease prevention. And I just keep coming back to this, and it's why are we waiting to address cardiovascular health? So if you think of, during the pandemic, employers really did a fantastic job of getting on to the mental health bandwagon. How can we up-level resources? How can we add resources if we don't have those? I will say depression and anxiety are one of the most common comorbidities with cardiovascular disease. So there is something to be said there. But there just doesn't seem to be an urgency around it. And Hannah, I don't know, as you've been working with your clients, kind of any feedback that you have on related to that. Like, we know it's there in utilization. It may not be there in cost until it is, right? So how do you advise clients related to a cardiovascular disease strategy?
Yeah, I think overall there's a lot of challenges. I think a lot of the individuals that it falls on to assess, HR has a ton of things on their plate, and other items just might take priority over tackling this looming issue that doesn't seem to be going away anytime soon. In addition to this, it's probably very difficult to critically compare one program versus the next as far as how to what to focus on, how to discern between the available options out there. And I think as a healthcare system as a whole, there's been a heavy reliance on physicians to play this role, but I think physicians can only do so much just because of the exposure that members have to them. I mean, they might see their doctors a couple times a year, whereas more robust solutions are likely going to be easier to access, so from a patient perspective as well. And I think lastly, of course, funding is kind of a big one as well, just finding the funds to invest in this space. And I think ways to get around that is either to have appropriate reporting and potential ROIs to kind of surpass that hurdle and result in the outcomes that you're really looking for.
Yeah, absolutely. If you're going to put a solution in place, you want to make sure your members are using it and that you're seeing financial returns on it. One thing that's kind of giving me a little bit of hope, again, showing my age, there was a point where there was no such thing as those automatic external defibrillators. Now you see them in basically all public buildings. You see them in a lot of large employers. So I think there was a moment there kind of in history where people were like, we don't want our members to have heart attacks, or our customers at work, we want to be able to give them this life-saving measure. And recently with the football kind of scare with Damar Hamlin having a cardiac event on the field. I've been traveling a lot. I've been in 3 different airports that now have in the airport a resuscitation mannequin to teach you how to do CPR. And I was really happy because my daughter and her friend, we were waiting for a plane and they ran over and they did it. I'm like, yes, this is the perfect way. You're sitting there with nothing to do, learn about these basic life-saving measures. But that's kind of at the end, right? So what can you do at the beginning? On the preventive side, and really what are all the impacts? You kind of alluded to it, Hannah, earlier when we were talking about heart health impacts more than just the cardiovascular system and the vascular system in general. So if you think about different solutions on the market, there's not solutions for every one of these conditions, right? And if you did, how would your members be able to manage all of these different solutions? But the underpinning one is cardiovascular disease and impacts on vision, dementia, sexual dysfunction. Those are things, as a health educator in my past and as an exercise physiologist, sometimes people are ready to change for not the reason that you would think. It could be something, very different. So you really need to meet people where they're at. And it might be that one of these other things are very concerning to them, and that could put them on a lifestyle change journey. So I think this is maybe an obvious question, but Hannah, are there specialty drugs for essentially everything we're seeing here, or some pretty high cost drugs?
Yes, there's absolutely quite a few. And I think specifically dementia and Alzheimer's, it's not intuitive that they're vascular diseases, but your brain is the most blood demanding organ in your entire body. So any disease impacting the vascular system is absolutely going to be affecting the brain. And just a couple specialty drugs off the top of my head, infusions, Aduhelm, and recently approved Leqembi are definitely going to be drivers in specialty spend for those diseases in the near future. And also a lot of the specialty products are going to be seen not only in the pharmacy benefit, but the medical benefit as well.
And that's really a challenge when you think about adherence, when you have to actually go into a provider's office. I mean, yeah, there's the additional spend, but I think Leqvio is the perfect example. Once you get, the initial kind of dosage right, if you miss that window on a very short amount of time, you have to start that reloading all over again. And I think, we're busy people and we miss appointments and different things like that. So it's really important to be able to manage that and looking for programs that are going to do a little bit more. So not just hypertension or not just cholesterol, but really combining that whole umbrella of cardiovascular disease coupled with a medication adherence tool will really get your members on the right track. So I've done this. I'm guilty, as I've seen patients in the hospital on cardiac rehab. You're like, okay, I'm going to help you with what you need to do. And none of these are earth shattering, but when you pile them on top of each other, it can actually be really difficult for people to be compliant with these lifestyle changes. And it's really impacts your motivation, and you kind of have like a negative perception of it. And I think that's why, somewhere around 50% of people who are prescribed chronic condition medications don't actually go get them filled. I don't want to have to deal with it. I don't want to think about it, a little bit of denial. So this makes it really complicated. One nice thing the AHA has recently done is they've created this Essential 8. It used to be 7. They've added sleep now. Essential 8 lifestyle factors. So kind of taking it back, being really simple. Here's things that, and there's a lot of health education material that's no cost to employers from the AHA. So definitely check out their website and kind of pull down some posters and e-content and copy and things like that. But really programs that are going to manage all of these things together, really focus on that lifestyle, will have not only impacts on cardiovascular disease, you could have impacts on mental health, you could have impacts in other areas as well. I just would be rats if I didn't point this out. We talked about the $10,000 a year cost, but there actually is a lot of waste, fraud, and abuse in the medical system related to cardiovascular disease. The FTA and FDA have been on a tear right now, going after different hospital systems for using stents unnecessarily. I think we've seen this as well with cesarean sections and different things like that, where we're kind of going above and beyond what's clinically indicated, and that's going to cost a lot more. It shows that in this study, 1 in 7 stents, so that could kind of be a first line. You're coming in and you're having a cardiac issue. You might get sent to the cath lab. 1 in 7 are actually unnecessary, and then they do harm, right? This is something physically and that is getting externally put into your body. And if you didn't actually need it, these are around $30,000, $40,000 per procedure. So you're definitely seeing these on your plan. It may not look exactly like this, but work with Hannah and people on your team to kind of parcel that out. If you do have someone who goes in and gets cardiac symptoms and they, cardiac procedures, then they need to especially be taking their medication after an event like that. So here's a couple other stats related to a bypass surgery. Let's hope no one on this call has to have one of those, but they're around $150,000, and that's if you get out of the hospital on time. The annual cost to the U.S. is around $229 billion, which is what's, again, leaning it to be the most expensive chronic condition. So we have kind of some good news, right? Some research that we want to show. It's not all doom and gloom with what's going on. You as the employer have an opportunity, and the consultants that are working with employers, to make an impact in these areas. And I just want to back up and say, we've talked a lot about cost and what it means to the employer, but these really improve people's lives. And that's a wonderful piece of being an HR professional, getting to put programs like that in place to help people's day-to-day lives. So looking at digital solutions that you can do that's going to improve the cost, but also support that medication adherence. This study was done with the Validation Institute. So can this happen? Can you move people in the right direction? And what this showed, if you think about that, around $10,000 cost. So after 1 year in the Hello Heart program, so this is a digital program, it's really focused on lifestyle coaching and medication adherence. And we saw our members save around $1,865 after 1 year in the program. To get in the Validation Institute, you have a whole team that's vetting your data. So Hello Heart was able to achieve the level 1 savings validation. And what was interesting to me when we worked on this with them is that Hannah, I was thinking we would save money in the cardiovascular specific procedures and different things like that. We knew we wouldn't see it on medication because the cost of the drugs are usually so low. But in fact, it was reduction in spend in all different buckets. So less likely to go to the ER, less likely to be admitted, going to be in that hospital a lot less. That $4,000 a day we were looking at a digital price. You're less likely to get all of those expensive imaging and tests to wonder, why isn't your hypertension under control, your cholesterol, when in fact we know it's most likely lifestyle is the main contributing factor. The most important piece of the study, though, was actually there was a 52% increase in primary care. So the app, anytime it sees like a clinical indicator that you should see a provider, it could be you're taking your medication regularly and it's not having an impact on your numbers. It could be that you're having blood pressure spikes, arrhythmias, different things like that going on, hypertensive crises. It's going to refer you to your provider through the app. It can help you make the appointment through the ecosystem of the employer. It can also help you find a ready clinic or a CVS minute clinic in the case that someone may indicate they don't have a provider. And weirdly, that's 40% of people with insurance haven't been to primary care in 3 years. So that is actually a popular feature. And I think part of these savings outcomes is you're going to have improvement because you are improving medication adherence, where you're driving people to providers and they're able to titrate up or down or swap out drugs because they're getting more data. The provider's getting that report, and it's like giving them more than that 1 or 2 data points a year. It's giving them a whole history of what's been going on so they can put together a better medical plan for your members at that point. I know we talked a little bit about social determinants of health, and essentially we see really poor health equity for African American, Hispanic, and then women overall, and Black women most in particular, related to cardiovascular disease. So this study was published in the American Heart Association, and it's a digital solution. So you're really breaking down all those barriers to care that are related to access. And there's a multitude of different ones. It could be trust in the healthcare system, it could be transportation, it could be lack of providers because you're rural or urban, different things like that. But what we saw in this study was that regardless of gender, regardless of ethnicity, race, or primary language, the apps in English and Spanish, we saw the same outcomes across all groups. And that's really what we should be striving for. You might be starting to see these on your medical plan reports now, where they report on either area deprivation index, social determinants of health. So you're capturing this information, you're seeing these inequities, but the next step is to move forward and take action with something to improve some of those inequities. And I'll just kind of recap, if there's sort of a call to action really for any program that you're going to put in, is the number one benefit is that it's engaging, and it gets a big part of your population who's eligible, and then they stay engaged in the long term, that it has clinical outcomes that are proven. So not a glossy white paper that the marketing team made, no offense, marketing people, and not published in the Journal of Internet Research. I will not tell you what group I know that has done that, but in a reputable journal. Ask your consultants if you're not sure what that looks like. And then it has to be easy for the HR team to put in. So if it has a really long implementation time, a lot of legwork on the HR team, that really can impact the ability to even put the solution in, period. So with that, just kind of in closing, it's all in your hands, like everybody on the phone right now, the employers and the consultants. You have the power to empower your members to make change and understand their heart health. And then you'll see that on the side of reducing costs. And I think we are probably going to go to questions if we have some questions.
Thank you, Jen. Thank you, Hannah. We do have some questions, and feel free to still drop them in that box, in that chat box. So we did get a few. So ladies, you talked a lot about costs, but one question we got is, what is the cost of doing nothing for cardiovascular disease?
I'll kind of start first, Hannah. I think you add all the numbers on your slide and all the numbers on my slide, and you really see the cost of doing nothing. And I would just say those people don't just stabilize at $10,000. They get riskier and riskier, and then you're a high cost claimant. I don't know, Hannah, what your opinion is.
I totally agree. I think in addition to just the financial costs of the disease as well, there's also significant costs to not only lifespan, but health span as well. And that's the time that members are staying healthy for longer and living lives that they're not dependent on maybe medications or procedures to continue. So I think from a personal perspective too, there's definitely costs regards to that.
Very helpful. Thank you. All right. One other one, and this may be a little bit more specific, but what if I have high turnover and a younger population?
Oh, I love that question because my mind was totally changed on this. So one, we saw those statistics where 68% of adults 18 and up. So people are getting high blood pressure and high cholesterol at a younger and younger age. So it's probably worse than you think, is what I'm trying to say on the age perspective. On the turnover perspective, that's a challenge. But what we have seen, at least in our program, is a little bit of a self-selection. So people who are you're younger and let's say you're in retail, and they're maybe going to be your employee for 6 months or 9 months, they're not likely to engage in a program like this. They're kind of in and out, if that makes sense. So what we see in general is kind of your people who know that they're at risk. And they may not be going to the doctor and they may not be taking medication, but they do know that they're at risk, that are engaging in the program. So that helps. We actually do have quite a few retail clients. We're going to be publishing a study for one of our very large retail clients coming out. And I was really pleasantly surprised with the engagement and sustained engagement in that population.
I'll chime in to that question as well. I think education, regardless of age and turnover, and just supporting lifestyle initiatives, you might not necessarily see the return on investment in the long term, but at least in the immediate perspective, lifestyle initiatives can help immediately. So that's just something to consider, the pros and cons of initiating a program.
That's a really great point. If you do small changes and they start stacking on each other, you feel better that day. And if you feel better, you're going to do better in everything you're trying to get done that day.
Well, talk about this kind of segues perfectly into our last question that I have showing up here. So maybe I'll start this one with you, Jen. How do I go about putting together a heart health strategy?
I think the first thing is commit to doing that. The CDC is asking employers to do it. The AHA is begging employers to do it just because about 60% of Americans get their insurance from their employers or their family member that's on an employer's plan. So in terms of the biggest pool and the biggest ability to make change in our country in terms related to cardiovascular disease, it is actually the employers. So I'd say, number one, talk to your consultants like Hannah and the team from Employers Health. Talk to your medical and your pharmacy account executives as well. Make sure you gather all of that data together. Have somebody do the legwork for you on it, one of your analysts that are on either of those teams as well. And then say, one, do I have a problem? And then do I have somewhere where I can make an impact for that? And then really commit to a strategy and make sure that you're doing great tracking so you can really solidly measure engagement. And then if that is leading to you toward cost savings.
And I can add on to that too. I think trying to meet your employees where they currently are, maybe potentially surveying the population if you have a couple of different opportunities that are on the table, maybe asking your employees themselves, what do you feel would be the most accessible to you? What would you feel most comfortable engaging with? And I think that in addition to all of the pharmacy and medical benefit assessments, it's something to consider.
I love that idea, the employer survey. Good point.
Mm-hmm. Well, great. Well, Jen, Hannah, that's it for questions. But please, if you do, you can see there's an email address there for Hello Heart if you do have any other questions, or feel free to reach out to your Employers Health Client Solutions team member. And we can, of course, connect you with Hannah or anyone else on our clinical team to get you the answers you need. So thank you, everyone, for joining us today. We appreciate you taking the time to be here, and I hope you and your families are staying safe and healthy out there. So have a great rest of your day, and thanks again. Take care.
Thank you.
Thank you.